A very good morning to all of you. I'm Dr. Diksha Pandey and you are watching Urogynecology for Beginners. And today we are here with yet again case of urogynecology which presented as a diagnostic dilemma. And we will not reveal the diagnosis in the beginning. Let's start the case and then we'll discuss how we reach the diagnosis and how we manage the patient. So to present the same case, as always, I have my two sweet fellows with me, Dr. Subriti Bansal and Dr. Dheera Samdaria. So who is presenting the history today?
Yes. Okay. Ma'am, this is Mrs. A. She's 54-year-old lady. She's para 3 living 3, postmenopausal since 12 years, coming from Haveri. She came with complaints of painful micturition since 3 years. Ma'am, patient was apparently normal 3 years back when she developed pain while passing urine since 3 years. It was associated even with burning micturition. Ma'am, she even complained of post-void dribbling of urine on and off. It wasn't a constant feature, but she noticed it sometimes. Ma'am, in this 3 years, she actually visited 3 doctors. First, she visited a urologist, ma'am, where she was given a course of antibiotics, where the symptoms subsided for a month, but they recurred again. She waited on it, then she again visited the doctor again, where meatal dilatation was done. Prior to the meatal dilatation, she'd undergone a uroflowmetry, and that was normal. So they thought like if there's any stricture of the urethra, so meatal dilatation was done. But her symptoms still didn't subside. Then she visited a gynecologist, ma'am. There she was diagnosed to have as a cystocele. She was given Avalon cream, and she was also advised a hysterectomy that time, because they said that since the tissues had become lax, so they needed to repair it with a hysterectomy.
Some kind of prolapse, they thought,
yes,
cystocele or
yes,
something.
Yes. Okay. Then she visited us, ma'am. She came to us in the month of December 2022. Yes, ma'am. When she came to us in the month of December, she continued to have painful micturition, burning micturition, and post-void dribble of urine.
So today we are discussing this case after 6 months of surgical follow-up.
Yes, ma'am. Yes, okay. Yes. She continued to have painful micturition, burning micturition, and post-void dribble of urine. There was no history of symptoms suggestive of SUI, no history of urgency or urge incontinence, and no history of. She did not give a history of mass per vagina. No history of painful intercourse. Yes, ma'am.
So this is a very common, if you look at the first presenting symptom, it is a very common kind of symptom which looks like cystitis. And without evaluating, maybe first episode is just treated like cystitis. And I think the same happened with the patient. But one very important thing what Dheera said today, that if there is cystitis, okay, frequency will be there, burning micturition will be there. And if it is recurrent kind of cystitis, usually there will be urgency also to patient. But this patient did not complain of any urgency. And one thing maybe where it went wrong, and this is something we have to remember, when uroflowmetry, flow was perfectly fine.
Yes.
There was no need of urethral dilatation. That means urethra was not obstructed.
Yes.
Okay. Because if the flow is perfectly fine, that means that outflow tract is
nothing like that.
And before that also, I will repeat it, I keep on saying many times, because female urethra is straight and only 3 to 4 centimeters in length, meatal stenosis is very, very, very rare in women.
Yes.
Okay. Whenever it happens also, it is post-dilatation.
Okay. Oh,
post-dilatation. Because somebody would have done dilatation like that, it would have got injured and
the raw surface
got fibrosed, and it is iatrogenic most of the times. So usually you remember it that most of the times 99.99% you have to try to rule out other causes before diagnosing a female patient as a case of meatal stenosis.
Yes, ma'am.
And many a times we keep on saying, seeing patients who have already undergone meatal dilatation with the diagnosis of meatal stenosis, but it is a very, very rare entity, and I will repeat it, most of the times it is iatrogenic in nature.
Yes.
Okay.
Now, post radiation, can it happen?
But radiation itself is such a rare thing to happen.
like
How
that.
many women
Huh.
would have gone radiation?
Yes, ma'am.
And they have many more symptoms to happen.
Yeah, rather than
They
this.
would have proctitis, they would have cystitis
Yes,
before,
ma'am.
because even if you are saying that for cervical cancer somebody gets radiation,
ma'am.
urethra is far away. Bladder
Yes,
and rectum
Yes.
are the first
First ones to get.
treated.
Okay, ma'am.
So that cannot be presenting symptoms
Yes,
right.
most of the times. So in medicine, always you think of common things, you will be
Better off.
you will be correct more commonly.
Yes,
Okay. So only one thing I want to you to remember, that if a patient really has meatal stenosis, maybe somebody, you go back and ask her the history, maybe somebody would have tried a meatal dilatation from
Yes,
her.
ma'am.
So women, we don't think, we rule out other anatomical causes. If anatomy is correct, then we look for physiological causes. Okay, that's how we go. So these are the normal things what happened with the patient, but this is the normal history of our patient. Most of the time they would have consulted a urologist, they would have
Over
consulted
years,
a,
gone to different people.
gynecologist. So gynecologist also, what we know we see there.
Yes, ma'am.
So they thought it is a cystocele. So we'll go move on to examination and we'll find out from SOF that what were the clinical findings before we come to a conclusive
Yes, ma'am.
diagnosis.
Ma'am, so she was a moderately built and nourished patient. Her BMI was within normal limits. Vitals were stable. When we examined her, her abdomen was also soft, non-tender, unscarred. Main examination findings, ma'am. Local examination.
How many children she has delivered?
She's para 3
Para
delivery.
three. All vaginal.
All vaginal delivery.
Yes, ma'am. So, ma'am, educated patient also,
Right.
this one. So, when we examined actually in the anterior vaginal wall, ma'am, we saw 2 by 2 centimeters swelling. It looked like a bulge only, right below the external urethral meatus. And, ma'am, no, it wasn't, there was no pus discharge on pressing or anything like that. It was not a tender one. And,
It
Uh,
was
it-
tender.
like,
It
I
had
don't-
tenderness.
sorry, sorry.
Yeah,
It was
I
tenderness.
think it was there.
It was tender, but no pus discharge and no demonstrable SUI and no other defects, ma'am. Like no anterior and
So
posterior
she did
defects.
not have, on examination, she did not have any uterine descent.
No.
She did not have rectocele. She did not have enterocele. She did not have cystocele. And even now, when you see just a defect or
Yes, ma'am.
loosening or some bulge at the urethra,
Yes.
my question to you is,
Yes, ma'am.
is your diagnosis urethrocoele?
Ma'am, we will look for tenderness also. Like
Okay.
we will look for tenderness, pus discharge.
Okay.
And
So why I ask this question
ma'am.
is, it is inspired by a few of the questions which I
Yeah.
have been asked in our
Yes,
channel.
ma'am.
Yes.
That how do you treat urethrocoele?
Yeah.
Okay. So let me make it very clear today.
Mm.
Urethra is just the conduit for urine passage.
Yes, ma'am.
Okay. Even if it relaxes,
Yeah.
okay, it can give rise to SUI because of bladder neck related problems. But urethrocoele, if it is totally lax, it will not. It will just maybe, if you do urodynamic testing, maybe her flow rate, the time which she takes to void urine might be little shorter. But otherwise, symptom-wise, urethrocoele, even if the tissues are relaxed, patient will not be symptomatic most
Right.
of the times, because just the urethra, if bladder, everything is fine.
Yeah.
Usually, isolated urethrocoeles are not seen also, and even if it is seen,
Yes, ma'am.
it will not present with symptoms.
Yes.
Okay. Many times urethrocoele, the common problems of urethra are urethral caruncle,
Yes, ma'am.
okay, urethral diverticulum.
Yes,
But I think for many years urethral diverticulum was not diagnosed and was diagnosed as urethrocoele. In
Or even
literature, also in
cystocele. Yeah,
private
like by
practice.
people. Yes, ma'am.
Yeah, okay. So what happens here, urethrocoele, just relaxation of, and those organs who actually have something to hold, like
Yes.
pouch of Douglas has intestine to hold, rectum has stools to hold, bladder has urine to hold. So these things tend to become lax.
Right.
When your function is not dynamic,
Hmm.
okay, it's not, you are not an organ of emptying and you don't have pressure to
Storage, yes, ma'am.
withhold, these organs usually do not become lax like that. Okay, so urethrocoele is not a very common symptomatic problem.
Right.
The more common diagnosis, which is the most important diagnosis we have to remember, is urethral diverticulum. Okay, and here why we are saying that it was urethral diverticulum. Before that, before we move on to the this patient, can you tell me in short what actually is a diverticulum, urethral diverticulum? Like intestinal diverticulum, when we say that is just the outpouching,
Outpouch.
structural defect.
Yes.
Some muscle has got defective and the mucosa has outpouched.
Yes.
Is urethral diverticulum the same thing?
Ma'am, basically a diverticulum, as you said, is an outpouching from a hollow viscus.
Yes.
But a urethral diverticulum is caused because of if they have repeated infections where there are paraurethral glands.
Very
and if
good.
they get
So it is
infected-
not just the outpouching. Though the name is urethral diverticulum, maybe it is a misnomer, but it is a gland which has repeated infection. And then what happens? Urethra has paraurethral gland.
Yes,
So
ma'am.
one of the glands gets infected. And
it can form an abscess, and when that abscess ruptures,
yes,
and that leak, and then when the abscess ruptures, that can form a diverticulum.
that can form a. So it keeps on expanding. When it is too dense, then it leaks at the, it perforates or it ruptures
yes,
at the urethra. From
yes.
there, initially there will be pus leakage, which or if you have given antibiotic, it will become just like a serous fluid. Patient will not realize only that there was a discharge to coming out of a urethra. So it can just go unnoticed also, that this particular finding because of multiple, like hydrosalpinx. Pyosalpinx, if you keep on treating with antibiotics, it becomes hydrosalpinx. Exactly the same way, if you treat with multiple antibiotics, what happens, this pus also becomes like fluid or serous in consistency, and if it leaks, patient will not realize that there was any discharge. But because it is a cyst, it keeps on getting, and when this perforation or this punctum develops here, urine can just go there and keep on getting accumulated, and whenever this urine is there, this urine can get infected again and again, because you know the urethral diverticulum are usually in the lower part of the urethra, and it is close to vagina, it is close to anal canal. It is much easy for these diverticulum to get infected, even if you compare it with bladder. Bladder is little far away. To reach the bladder, bacteria still have to travel from the perineum to the bladder. Here, it is just next to that organ, and if it has good material, like urine is collected there, they will go every time there and start forming colonies there, and patient will be symptomatic again and again.
So that's why in the history, like she was given a course of antibiotics and then her symptoms subsided for some time, but it recurred again.
Exactly, because there is no drainage for that. Okay, so every time urine is coming, getting collected there, after some time bacteria are going up, infecting the collected urine, and it is that puddle is becoming infected again and again. Okay, so the typical history will be patient will have recurrent episodes of UTI, lower urinary tract infection. You can say it as. Patient cannot say that, but usually these are not associated with suprapubic pain or urgency. Okay, this is one finding which you might see to differentiate cystitis from urethra. But more important will be the clinical examination. And clinical examination, when you sweep your finger, we say for urethritis also, you have to sweep. If the patient complains of these kind of findings, it can be urethritis also. So you have to sweep your finger along the antevaginal wall, from the bladder to the urethra, and ask what is the point of tenderness to the patient. And in this case, if we sweep our finger, we get a cystic or boggy swelling in the urethra. Okay, it was typically seen in this patient. There was on speculum examination, there was a bulge. If you see, it might look like a urethrocoel. Okay, but when you feel it, it has a nice cystic consistency to it. And if it is still connected, if it is infected and still connected to the urethra, sometimes it can again stricture can form there. This can also happen. And but if it is still connected and if it passes inside that, if you press, you will see that from external urethral meatus some pus discharge. But all those findings were not there in this patient. Her history and examination, when cystic swelling was seen, small cystic swelling, which is easy to get missed. It was not like if you have not seen, you are very likely to miss that swelling. So this is the typical finding of urethral diverticulum, which is more common than you think it is. Okay. Then how do you confirm this diagnosis? If this thing comes in your mind, you have to do some test
Yes,
to
ma'am.
confirm this diagnosis. What test do you want to do?
Ma'am,
Ma'am,
first
hmm.
we'll do the ultrasound.
Yes.
Yes,
So we
ma'am.
do the ultrasound. And what ultrasound? When you are, suppose you don't have an ultrasound machine in your vicinity.
Oh.
If you are sending the ultrasound, what exactly? Because you have to write what ultrasound you want to be done for this patient. If they do TS, it will not be detected.
Yes, ma'am.
If you even do TVS and if you
Yeah.
put the probe inside, it will not be detected.
Yeah, probe
So,
at the introitals.
so it is specifically introital scan you have to
Okay,
do.
introital scan.
Okay, so introital scan you do, that is done with TVS, normal TVS
Yes,
probe,
probe, yes.
and you move it anteriorly.
Okay.
Okay,
Right.
and
That's
then what do you see? Did we see?
Yes, ma'am. And we saw the external urethral meatus as a circular opening, as a circular structure, and we saw another cystic structure below it.
Yes. 2 into 2 centimeters, just cystic structure, like you see a follicle in TVS. Exactly like that, 2 into 2 centimeters swelling was seen just below the urethral meatus. Okay. If you have, we can show the pictures, or we'll see later how it is.
Yes.
And
Okay.
to confirm, ma'am, we
Yes.
went ahead, yes.
If you have to confirm it
Yes,
further,
ma'am.
though our diagnosis was very
Yeah.
sure,
Yeah.
but for
And even
more of
clinical
academic
features. Yes, ma'am.
purposes, we wanted to do further investigation
Yes,
to
ma'am.
confirm the diagnosis and
We-
what is the best
Ma'am, MRI would be the
MRI.
best.
So when you do MRI, and
Yeah.
it is for surgical planning also a
Yeah.
bit to see the size and extent, and there can be sometimes two diverticulum also. Okay, one might be collapsed that particular time,
Okay.
and one can be there. Okay,
Yeah.
so before you take surgical plan, it is not mandatory, but for academic purpose, we did MRI actually for her. So did we do any special technique
ma'am.
to do the MRI?
Ma'am, so we did, we pushed in lignocaine jelly through her urethra that time. So
Okay.
that helps us localize the.
So if the punctum is open,
Yes, ma'am.
we expected that the jelly might go inside the diverticulum
Yes.
and it can show the connection.
Yes,
But
ma'am.
in this very patient, there was no
connection.
demonstrable connection between the two. So this is normal because it is like a pinpoint hole,
Right.
which
Yeah.
might just close sometime,
Close
it might
sometimes.
just open sometime. But if it is, there is a diverticulum, there is a chance that she might present with those symptoms
Yes,
again and again. Okay. So we did MRI and the our diagnosis was confirmed.
Yes, ma'am.
Okay. So once your diagnosis is confirmed, what is the treatment? Should we give her again antibiotics?
Surgical
Yeah.
excision,
Yes.
diverticulectomy.
Yeah. Diverticulectomy is the treatment because you keep on, the same history will repeat itself. You keep on giving her antibiotics, patient will be relieved for some days, again
And
the,
again it will recur.
infection will happen again. So the procedure is a surgical procedure and it is called urethral diverticulectomy. Okay. So have you done it?
Yes, ma'am.
Yes. Who will tell me the steps of important steps of diverticulectomy?
Yes. Ma'am, before starting the procedure, first we did a urethroscopy to see if you're able to see the opening of the diverticulum, but unfortunately we couldn't see the opening.
But we knew that
But
MRI
yes, ma'am.
also was not saying.
Yes.
If we would have seen it, it would have been like
Better.
really
Yes,
good.
ma'am.
But we knew, we had an idea that the connection is close
Yes,
now.
ma'am. Even on the MRI, it said that the diverticulum is in the posterior aspect of the urethra. So after doing the urethroskopy.
So usually these diverticulum will be in the posterior, dependent part of the urethra.
Right. Yes, ma'am.
More likely to happen.
Ma'am, we put an incision in the anterior vaginal wall. We can either put a U shape or we put a vertical incision over the swelling. We raise the vaginal flaps and then we open the periurethral fascia and we conserve that also separately. And then we could see the diverticulum, which we excised completely. And
So excision of diverticulum is the important thing. It's not just drainage like any other swelling. If you just drain it like Bartholin cyst, if you just drain it, it is bound to recur. So you have to excise the entire cyst. That periurethral cyst has to be excised,
Yes.
or you can say diverticulum also. The entire thing has to be excised if you want 100% results.
Yes.
Okay.
ma'am, the small defect was closed vertically.
So when you do this,
Right.
when you remove this, you will injure iatrogenically
Yes,
the
ma'am.
urethra because you, while removing, it is not possible to not to open the urethra in that. Okay, so don't worry when the urethra is open. What do? We just suture it with continuous sutures. Which suture material you use?
Ma'am, Vicryl, delayed absorbable, Vicryl 20.
20, 30, anything you can, and just close the urethra. Now, what is the problem? What is the problem of if suppose what are the problems you are anticipating, or what are the precautions whenever you close the urethra?
Yes, ma'am.
Maybe we have discussed this in the beginning. What is the complication you can anticipate?
Stenosis.
Iatrogenic stenosis. This also can be a cause. So you have to remember that though you have worked from the vagina, but you have to keep the catheter for a longer time. At least 3 weeks you keep the catheter, so that iatrogenic strictures are not formed. So that you will remember, catheters throughout the surgery, catheter was there. And we will keep the catheter for longer duration. Okay, so urethra you have closed.
Yes.
Then, as you said, that we have dissected separately to give it a nice closure, and to prevent the recurrence we will take paraurethral tissue. One nice layer of paraurethral tissue and approximate it.
That was closed horizontally, and our vaginal flaps were closed vertically.
That's for any fistula or any kind of two different organs. Whenever we close, to avoid friction, we always do perpendicular to each other closure. So we close that horizontally, and vagina, then antevaginal wall was closed vertically to that. Okay, so 3 layers closure. One is the urethral wall, then paraurethral tissue, and the vaginal wall, and the surgery is done. Okay. So diverticulectomy was done. How was the post-operative follow-up of this patient?
The catheter was put in situ, ma'am, for 3 weeks. So we sent her back with that catheter, and then that was taken out after 3 weeks. And
so 2-3 days later, patient was sent home and called after 3 weeks for catheter removal.
Yes, ma'am. And she was able to pass urine comfortably after that was removed. And then 6 months later, ma'am, she came to us again to show, so she has no complaints, and she's
perfectly fine. No further episodes of that burning micturition. She is a happy patient now. So it was a small surgery. People have advised her so many things: hysterectomy, cystoscleral repair. Even if you would have done those major procedure for this patient wouldn't have been recovered from her symptoms. Okay. So this was again a very small and fulfilling case. So important thing, I wanted to discuss this case today because recently I read a comment on one of the videos that what is the surgical management of urethrocoel if it is there. So first thing what I want to say is that urethrocoel itself to present individually as a stand-alone problem is a rare. I have yet to see one. I have not seen a patient where patient has just presented with the urethrocoel alone. Even if little bit of urethrocoel sometimes is there and patient is totally asymptomatic, with prolapse cases where you are repairing, you don't have to repair urethrocoel. Sometimes urethrocoel will be seen in those patients where a patient has SUIs. Okay. So when you put the tapes, urethrocoel is taken care of. That is one of the management. That is the third group of patient. And so that's what urethrocoel, if you are feeling any patient of yours has come to you who looks like a patient with urethrocoel, please examine her think of a possibility of urethral diverticulum, and if it is there, we have already told you how to diagnose it and how to manage it. Anything you would like to add on this case?
Ma'am, it was an interesting case, and it was the first time that we saw urethral diverticulum and in surgical treatment.
And this thing, we recently have another patient whose MRI we are awaiting. So that patient, if she comes, we'll update you on that also. So thank you so much. Hope you learned something new today. Thank you.
Thank you.